We can start.
Hello, good evening all. I am ISS Secretary Nanded. Welcome all of you on of our behalf of topic case meet 19. On this evening with us Dr. Joyshankar Jana sir. He's a associate professor and senior consultant working at KEM Hospital Pune and Galaxy Care Hospital Pune. He's a well-known person in all over India and in Asia also. The awards are Best Paper Presentation Anesthesia for Robotic Surgery in 2010 Misocon, even also Esecon, Anesthesia for Robotic Surgery also. Its publications are in international and nationals a lot. Area of interest is robotic and advanced laparoscopic surgery, anesthesia for cochlear implantation, anesthesia for kidney, liver and uterine transplantation, which is a worst anesthesia for uterine transplant, first in India and Asia also. Positions at presently, sir is president in ISP Pune. Just now elected. For that, congratulations, sir. He is also governing council member of ISA National 2016-19, governing council member of ISA Maharashtra 2012-16, honorable secretary of AOA Pune City, past treasurer ISSP Pune City, and now he is president ISSP Pune. Even is one of the best things first in India and Asia, sir had done anesthesia very much publicized in all medias, and anesthesia for cesarean section also done on that patient or after uterine transplant. So I'm very much welcome you, sir, on our case meet.
Thank you.
Thank you, sir.
First of all,
Please start, sir. Yes, sir, please start.
hello, am I clear and audible? Thank you.
Yes, sir. Yes, you are clear, audible.
Yeah, thank you so much, ISN Nanded, and for allowing me to in your case presentation meeting. And I start my presentation with honoring the respected chairperson, respected seniors, and my teachers, and my dear friends. President of ISA Nanded, Dr. Prahlad Kotkar sir, President, Secretary ISA Nanded, Sachin Chandrokar sir, and President-elect Dr. my very good old friend Dr. Someshwar Putanke sir. So with this, I'll share my screen now. Okay, sir. So my topic today is anesthesia for laparoscopic surgery and robotic surgery. And I've been practicing anesthesia for laparoscopic surgery since 1992. And it's been more than now 30 years. And I've practically seen the full development from the basic of laparoscopic surgery to the advanced laparoscopic surgery. In the good old days, we used to have the basic instruments for basically gynec and surgical procedures, basic insufflators, basic cameras. Till the now, we are the advanced laparoscopic system in last 30 years. So much things have developed, and which includes even thoracoscopic surgeries, bariatric surgeries, pediatric surgeries, and now even robotic surgeries. So this is a fantastic phase of my life, which I've seen in the last 30 years of my practice. So with the progress and the technological development in laparoscopic surgeries and more better understanding of laparoscopic anatomy and of course laparoscopic surgical physiology, it has indeed become more safe and safe as we evolve throughout the years. So much so that even, so this is the thing from basic laparoscopic surgeries to advanced laparoscopic surgeries. Technological development has taken place, better understanding, of course, I told anatomy, and of course, better understanding of laparoscopic physiology. I mean, I remember in the early 1990s, if you get a case of laparoscopic, even appendicectomy, we used to get tremors because we had to be there for at least 4 to 6 hours and then it used to get converted to open. So a huge change in the last 30 years. So much so that even the patients now demands a keyhole surgery because they don't want any scars in the abdomen. So what are the expectations of a laparoscopic surgeon from the anesthesiologist? Definitely not like this. It has to be absolute teamwork, and every member in the team, whether it's the anesthesiologist or the surgeons, should know all the various problems and the complications due to laparoscopic surgery, all the physiological changes in laparoscopic surgery, and should know also how to manage it. So during laparoscopic surgery, there has to be a moderate degree of hypotension. You do not give a deliberate hypotensive anesthesia. The bowel has to be retracted and contracted so that to prevent the various injuries. There should be excellent muscle relaxation. There should, of course, there should be early recovery from the surgery, and of course, good post-operative pain relief. So the physiological changes during laparoscopic surgery and the fallout in the patient's body are due to the various following factors. So basic is the pneumoperitoneum, which has all the laparoscopic changes. The patient position, whether it is head up, head low position or lateral position. Hypercarbia because of the CO2 which has been used. Reflex increase in the vagal tone because of pneumoperitoneum. And the anesthetic techniques and the drugs which we use for the laparoscopic surgery, giving anesthesia. So as the surgeons and the gynecologists go and attend the various CMEs and the workshop to update the laparoscopic surgical anatomy, we should also update our laparoscopic surgical physiology. That is the main thing. So what are the various laparoscopic physiological changes in the body? Is that first we'll go to the cardiovascular system. So there's a rise in the mean arterial pressure of more than 30%. The systemic vascular resistance is raised more than 60%. There's an increase in the vascular venous resistance. There's a decrease in the cardiac output. There's a decrease in the venous return and the decrease in the cardiac index. This decrease in the cardiac index is directly proportional to the set intra-abdominal pressure. And of course, there are the arrhythmias. So what are the various causes of decrease in the cardiac output? So these are the various causes of decrease in the cardiac output: decreased venous return, increased systemic vascular resistance, and increased venous resistance. What are the causes of systemic increase in systemic vascular resistance? Is that because of the pneumoperitoneum and the stretch of the peritoneum, there is a release of vasopressin, catecholamines, and the renal angiotensin system. So the net effect, there is a significant rise in the heart rate and the blood pressure. So what are the causes of cardiac arrhythmias? So these are the various causes of cardiac arrhythmias: reflex increase in vagal tone, vagal stimulation if your level of anesthesia is a little light, hypercarbia sensitizing the heart to halothane. Of course, nowadays we are not using halothane that much. We are more into sevoflurane and desflurane. So this hypersensitization due to hypercarbia and halothane is not really seen. And of course, venous gas embolism. And sometimes after creating the pneumoperitoneum, there can be a sudden cardiovascular collapse. So what are the causes? Sudden pneumoperitoneum. That means you put in a trocar and you create a sudden pneumoperitoneum. You can get a sudden cardiovascular collapse. The peritoneal stretch causes a vagal stimulation and can cause a cardiovascular collapse. There is a compression of the IVC leading to decrease in the venous return and decreased cardiac output, leading to cardiovascular collapse and cardiac decrease and cardiac arrest. Hypercarbia and unnoticed massive blood loss. That means if your trocar or the varus is in a great vessel, and venous gas embolism. I'm going to talk a little about venous gas embolism in my later in the talk. So the threshold set intra-abdominal pressure at which minimal hemodynamic changes are seen is between 12 to 14 millimeters of mercury. This has been calculated after many animal experiments on the monkeys. So this is the value which has been developed, that the minimal hemodynamic changes are seen between 12 to 14 millimeters of mercury. To minimize these changes, it is advisable to create pneumoperitoneum at a slow rate. That means you don't put a trocar and suddenly start gas insufflation at a very high rate. So you put a trocar, start the gas insufflation between 200 to 300 or to 500 ml per minute till you get the set intra-abdominal pressure, and then maintain the gas flow between 1 to 3 liters per minute depending upon the various leaks and while changing the various instruments. So what are the other regional hemodynamic changes? First is the liver. There is a decreased blood flow to the liver because of the pneumoperitoneum, which can lead to acute hepatocyte injury and increase in the hepatic enzymes. Then there is a decrease in the splanchnic blood flow. which can lead to ischemia to the bowels and the change in the mucosal pH. There's a decrease in the blood flow to the kidneys, which can lead to decrease in the glomerular filtration rate, and which leads to decrease in the urine output, decrease in the sodium excretion, and creatinine clearance. So, what are the changes in the kidney? Because of the decreased cardiac output and the cardiac index, direct mechanical stimulation of the renal vasculature due to pneumoperitoneum, and neurohormonal responses, stimulation of the renal angiotensin system. All this will cause a decrease in the urine output, decrease in the sodium excretion, and creatinine clearance. Now, what happens to the intracranial thing? The cerebral venous stasis due to the decreased venous return and head lobe, especially when in the head lobe position and in pneumoperitoneum, there is a decreased venous return from the brain and the head and neck. So there is a cerebral venous stasis. There is also increase in the lumbar venous flexion. So that also includes in that. And because of tachycardia and blood pressure, there is increase in the cerebral arterial pressure. All this will, and along with hypercarbia causes cerebral vasodilatation. So there will be an increase in the volume in the brain. So there is an increase in intracranial pressure. Though these are not aggravated in a normal patient, but if a patient has a CNS pathology like a tumor or operated some BP shunt or some pathology in the system, this can get aggravated. So you have to be careful. Then there's an increase in the thromboembolic phenomenon. Due to venous stasis, intraabdominal pressure is raised, the blood flow from the veins on the legs are decreased, and in the head-up position, for example, we are doing a laparoscopic. So there is a venous stasis. So those patients who are prone for DVT will definitely need prophylaxis for DVT, especially for thromboembolic phenomenon. Then intraocular pressure. Though intraocular pressure is not changed, but you have to be very careful if the patient has history of glaucoma. So while history taking, if the patient gives the history of glaucoma, you have to be very careful. Please refer these patients to the ophthalmologist and find out what type of glaucoma it is, whether the patient can sustain the laparoscopic surgery. Because if there is glaucoma and there is a raised intraocular pressure, patient can go blind. So better if you have a patient with glaucoma and refers to while taking consent, please mention this: the patient has glaucoma, is the risk of retinal damage or risk of loss of vision or diminution of vision. Then comes the changes in the respiratory system. So the respiratory system changes as increase in the intrathoracic pressure, decrease in the functional respiratory capacity, increase airway pressure, decrease in the tidal volume, decrease ventilation or increase the differential ventilation perfusion mismatch. There's an increase in the lung and the chest wall impedance. These changes get aggravated, especially in severe head lobe position. However, it is seen again with a set internal pressure between 12 to 14 millimeters of mercury. The pressure with a significant, whether it is head low or head up, is 10 to 20 degrees. There is no significant changes in the physiological dead space or a shunt in a normal patient. So what are the other physiological changes of the respiratory system? So because of carbon dioxide, there is an increase in the partial pressure of carbon dioxide in the arterial blood. So increase in the PaCO2. This is because of absorption of carbon dioxide directly from the peritoneal cavity. Then vacuum mismatch perfusion because of increased physiological dead space because of abdominal distension, head low position, and decreased cardiac output. If the patient is on spontaneous, of course, nobody keeps now the patient in spontaneous respiration. If there's improper mechanical ventilation, then again there's a proper increase in the PaCO2, increased metabolic events and accidental events like subcutaneous emphysema or even retroperitoneal emphysema, pneumothorax, CO2 embolism, and of course endobronchial intubation. That is, the tube has migrated in one of the bronchus because of the head low position. So the net effect of all these changes are that there is a severe respiratory acidosis and tissue acidosis. To minimize this effect, we have to increase the minute ventilation by 20 to 30%. It is more important to increase the rate of respiration rather than increasing the tidal volume. Also, during the positioning, always check for the correct position of the endotracheal tube, especially during the various types of position, whether it is head low, or lateral position. But if the PFT shows if the patient has a forced expiratory volume less than 70% or diffusion defect less than 80%, These are the patients you have to be very careful. These are the patients who are prone for developing hypercarbia and respiratory diseases and may require post-operative elective ventilation. So if the PFT, if you have advised, and this shows these values, you have to be very careful. Does your hospital have all these conditions? And the patient has to be explained that because of a PFT, you may need post-operative elective ventilation. Then what are the other problems during laparoscopy? Extraperitoneal insufflation. It could be subcutaneous emphysema. Of course, we have seen this. We can palpate the subcutaneous emphysema right up to the neck. Even retroperitoneal emphysema, that is also equally important. Then there can be pneumothorax, pneumomediastinum, and of course, ocular or scrotal emphysema. There can be aspiration of gastric contents, especially because of increased intraocular pressure and severe head load. There can be aspiration of gastric contents. So proper NBM and gastric prophylaxis has to be given. Then comes the bowel distension. Especially in advanced and prolonged laparoscopic surgery, it is usually the large bowel, that is the colon, which distends. Colon always contains gas. Even if you're given a good bowel preparation, it contains some amount of gas. This gas in the colon expands because of the absorption of carbon dioxide and nitrous oxide if you're using nitrous oxide. And once it expands, then it is prone for injuries, and it also decreases the intraoperative surgical vision. So this is how it looks. So if this colon is this much distended, definitely the operating vision and the operating space definitely goes down. And of course, this colon is definitely prone for injuries. Then comes the another problem is the shoulder tip pain. This is usually the referred pain which occurs due to pneumoperitoneum and the stretching of the diaphragm. It is more common in patients where there is spillage of bile, blood, or intestinal contents and constant use of suction irrigation. It is the formation of carbonic acid because of carbon dioxide and water vapor. Carbonic acid is formed, and this carbonic acid stimulates the diaphragm, and that's why you get the shoulder tip pain. Then comes the positional injuries, hyperextended arm. So if you have not kept the arm properly and you have kept the arm like this, and it goes up and up and up like this can lead to hyperextended arm brachial plexus injuries. Prolonged lithotomy positions, lithotomy injuries, and of course extreme head load. If you are using shoulder braces, then there can be brachial plexus injuries if you are in a head low position. Then comes the problem of hypothermia. This hypothermia problem is you have to tackle it very aggressively. Please don't neglect this point. Hypothermia is one of the biggest thing in advanced or prolonged laparoscopic surgeries. So cold insufflation of carbon dioxide, 0.2 to 0.3 degrees fall happens with every 50 liters of cold carbon dioxide gas which is inflated. Use of cold irrigating fluids, that means you want to clean the scope, you want to use irrigation fluid in the peritoneal cavity, there's a fall of temperature. And of course, your ambient temperature of the OT, if your OT temperature, AC temperature is low, they can lead to hypothermia. And of course, the cold use of anesthetic gases. Then comes the iatrogenic problems. So injury to the organs and the various and to the intestines. If your trocar or the thing injures while putting it blindly, so you have to be very careful while putting the trocars and the various needles. And of course, the money factor, of course, which I'll not go into the details of the money factor. Now, some special conditions. So if you have a pregnant lady who is coming for laparoscopic surgery, what are the physiological changes in the pregnant lady and what are the effects on the uteroplacental circulation? So first is the cardiovascular system. Severe hypotension can occur due to pneumoperitoneum and compression of the aortic cables like supine hypotension, which can aggravate in head-up position and can severely decrease the uteroplacental circulation, causing a fetal distress. Then comes the respiratory system. As pregnant ladies, there's already decrease in FRC and dead space. So these patients try to develop immediate hypoxia and hypercarbia, which can cause to fetal distress. So you have to prevent hypoxia and hypercarbia. So you have to maintain a normocapnic ventilation. ETCO2 should be between 30 to 35 millimeters of mercury to maintain a normal uteroplacental circulation. Of course, maintain an adequate hydration for optimal urine output. Pregnant ladies are, of course, in the hypercoagulable state, we know, so they are prone for DVT. So DVT prophylaxis must be given in a patient for laparoscopic surgery in pregnant ladies. Of course, delayed gastric time in pregnancy, so risk of gastric aspiration. So the fetal well-being depends upon the proper maternal management and maintaining a proper uteroplacental circulation. Last point, if you can see, the last is the removal of fumes and gases. Removal of fumes and gases is very important during the use of electrocautery. If you're using a unipolar or a bipolar, once you use that gas, there is a gas which is emitted. This gas contains carbon monoxide, which competes with hemoglobin to form carboxyhemoglobin and methemoglobin, which immediately crosses the placental barrier and can cause fetal tachycardia, fetal acidosis, and fetal distress. So when you're using a unipolar cautery or a bipolar, you must always have a suction to suck out the films. Of course, now you have the harmonic scalpel. So these incidences of with hemoglobin and carboxyhemoglobin are definitely gone down. Now the two commonly used gases. Uh, Nobody uses air now. I mean, 25 years ago when I started my practice, air was very commonly used because CO2 cylinders were not available. It is out of question, and properly is the CO2 is the gas recommended. So the medical grade carbon dioxide is approved by FDA for use of the gas for laparoscopic surgery. So the advantage of carbon dioxide over CO2 is that it is more soluble in blood. The capacity to carry carbon dioxide in blood is high. It is rapid elimination. If CO2 embolism occurs, there is no bronchoconstriction and lung compliance is not changed, and the lethal dose of carbon dioxide is 5 times that of air. Now let's discuss the most deadly complication, though it is rare, but you must know how to treat it, is during laparoscopy is venous gas embolism. So venous gas embolism is causes are direct insufflation of the gas into the vessel directly. That means you put a varies and it is in the vessel and you start the gas without confirming it, and you get a venous gas embolism. Or gas embolism which occurs from open blood vessels into the total circulation. The consequences and the effects of gas embolism will depend at the amount of the gas which is absorbed and the rate at which is absorbed. So if it is 0.5 ml per kg of gas, it will cause changes in the Doppler sound and increase in the mean pulmonary pressure. These amounts of the gas usually get absorbed in the pulmonary circulation. But if it is more than 2 ml per kg, then you will get a full-blown signs of venous gas embolism. So how to diagnose it? You can see there is tachycardia, hypotension, hypoxia. The jugular veins gets turgid, JVP gets raised. ECG will show a right ventricular strain pattern. There can be pulmonary edema and of course cardiovascular collapse. ETCO2, that is why we always keep on stressing that during laparoscopic surgery, we must have a ETCO2 monitor. It initially shows a sudden increase in the ETCO2, then followed by a sudden decrease and come down to zero when there is venous gas embolism. And then finally complete cardiac arrest and collapse. And in this, all this commotion which is going on, if you have a stethoscope, you auscultate, you will have a murmur called as a Wilming murmur. I have not heard it yet because it is quite rare. It is commonly seen in laparoscopic renal urological surgeries like nephrectomy or adrenalectomy or radical prostatectomy, when the renal vein or the adrenal vein or the deep venous plexus of the penis gets open. So these are the things, or endoscopic removal of thyroid or the endoscopic removal of radical neck, which we commonly do. When the neck veins can go open, then we can see the venous gas embolism. What are the various ways to prevent it? So careful aspect for the blood before you start the insufflation. Once you start, the insufflation rate has to be slow and in the beginning. Maintain intraabdominal pressure less than 14 millimeters of mercury, and of course volume preload. In spite of all these precautions, if you encounter a gas embolism, up till now I have encountered 4 times gas embolism, you must all know how to manage and treat it. So the treatment is stop gas inflation immediately, release the gas from the peritoneal cavity, give the patient a position called as a Durant position. What is a Durant position? A steep headlock position with the left lateral decubitus. That means it will prevent the gas from the right ventricle to enter the pulmonary circulation. Stop nitrous oxide and all inhalation agents. Ventilate with 100% oxygen. And if condition does not improve, we can put a CVP line. This is all technical. Put a CVP line, aspirate the gas from the apex of the right ventricle, or put a pulmonary artery catheter to aspirate from the pulmonary circulation, or start inotropic drugs if there is hypotension, and of course external cardiac massage is complete cardiac arrest. And in the higher centers, which is I don't know, I have not seen it, you can give a cardiopulmonary bypass or you can start hyperbaric oxygen therapy. So till now, we have discussed about the surgical physiology, the laparoscopic surgical physiological changes and the complications because of neoperitone. Now let's discuss the medical management and evaluation and how to give a better perioperative care. History taking, history of medical illnesses and allergies, physical examination of all the systems of the body, investigations, biochemical investigations, hematological investigation, imaging, X-ray, chest, ECG, 2D echo and PFT, depending upon the type of surgeries and the type of cardiopulmonary problems they have. Physician fitness. Physician fitness should be only taken for the medical problems they have. Other the rest all we can definitely manage. In the pre-op preparations and pre-medications, kneel by mouth for 6 hours for solids and 4 hours for clear liquids. Written consent, this is most important. Written consent, patient and the relatives must be explained that this operation will be done laparoscopically. But if required during the surgery, you can get converted to open surgery. So this written consent is must, because if there is only consent for laparoscopic surgery and you in the middle of the surgery want to convert it to laparoscopic from laparoscopic to open surgery, if you don't have a consent, you can be in little trouble. So take consent for both. And patient has to be, of course, explained for all the limitations and complications for the pneumoperitoneum and laparoscopic surgery. Pre-medications, antacid, antiemetic, antibiotic, anxiolytic, routine, nothing different. Continue all medication for the medical problem the patient has. Ball preparation. Ball preparation starts the day or the night before the surgery. It is very essential, especially if you're doing a pelvic surgery or a ball surgery. Preparation of the OT. So it's nothing different. So you check all your equipment, surgical equipment, ball machine, your equipment, anesthesia workstation, OT tables, all the pressure paddings, emergency and cardiac drugs. You check for all the warming devices. You warm your IV fluids and irrigating bottles. Open trolley. Now, before starting and preparing the sister or the brother who prepares for the laparoscopic trolley, first he must arrange the open trolley and then start the laparoscopic trolley. Patient should be the last one to enter the operation theater. This is a very important point. Usually it is always the reverse. The patient enters first and then the sister will spread. To be anesthesia, I'll start arranging. Never do that, especially for advanced and prolonged laparoscopic surgery. Open trolley is certain, then laparoscopic surgery is trolley, and then the patient enters the OT, the last. Then certain points we'll discuss regarding the anesthesia and perioperative management. So general anesthesia with cuff endotracheal tube with controlled ventilation in closed circuit is of course the safest. Epidural or spinal with general anesthesia in advanced and prolonged laparoscopy is definitely useful. So what are the advantages of combining a regional technique with general anesthesia? We have a good hemodynamic stability. It avoids sudden hypertension and sudden tachycardia. It reduces the anesthetic requirement for general anesthesia. Due to the sympathetic blockade of the epidural, the bowel gets contracted and the distension of the bowel is prevented. There is a quick recovery. And of course, the epidural anesthesia which you have started can be continued in the post-operative period for post-operative anesthesia. In advanced prolonged laparoscopic surgery or pelvic laparoscopic surgery, where the bowel is going to be involved, where you do not want the bowel to distend, then what to do? A good bowel preparation is good. Epidural or spinal for giving a good sympathetic blockade. You can give GA with TIVA without the use of nitrous oxide, oxygen and air, and you can maintain anesthesia with epidural and TIVA. So this is TIVA. So this is, if you just see, this is the bowel just after giving a plain GA. And this is after 3 hours after giving plain GA. So this is an impossible situation for any person to operate. Operating space has decreased, the bowel is distension. This bowel is definitely going to get injured. If you have given spinal plus GA, you can see the bowel is totally contracted. If you have given epidural, you can see that even the epidural effect, the sympathetic effect, the bowel is contracted. And just see, after 3 hours, the same patient with epidural GA, bowel is distended, not much, but it is contracted. So the surgeon can still go on contracting even after 3 hours. Intraop monitoring, basic monitoring, of course, I can say ECG, NIBP, SaO2, ETCO2. ETCO2 is must. It is in our ISA guidelines. So any laparoscopic surgery where ETCO2 is must. Of course, then For advanced laparoscopic surgery, you need urine output with urine meter to monitor the urine output, temperature monitor, peripheral nerve stimulator, airway pressure monitor. Usually it is there in the all the workstations, and intra-abdominal pressure monitor. Usually it is, initially we used to put a separate trocar to measure the intra-abdominal pressure monitor, but now it is inbuilt with the insufflator. Invasive monitoring, it depends upon whether you want to put a central line or a pulmonary artery catheter or arterial line. Depends upon the type of surgery and the blood loss and the medical condition the patient has. So, and the expected blood loss you are expecting. Then how to prevent the hypothermia, which is very important. So I'll just go through it. This is a workstation. Initially, we didn't have this workstation. We were initially in practice. We had the usual Boyle's machine. So this is a multi-parameter monitor. You can see it has got EtCO2 inbuilt. Now this is a portable EtCO2 monitor. You can just, if your hospital doesn't have a EtCO2 monitor and you're doing a laparoscopic case, you can use this portable EtCO2 monitor, very easily available, quite cheap. So hypothermia, prevention of hypothermia in any advanced and prolonged laparoscopy or robotic surgeries is very important. So causes of hypothermia, as I already discussed, cold IV fluids, cold irrigating fluids, cold insufflation of carbon dioxide, wet drapes, air conditioning, cold anesthesia gases. So prevention. So this is an age-old, most of the young anesthesiologists or the PG students may not have seen this closed circuit. So now they have this inbuilt in the workstation where this is a carbon dioxide canister. Then this is a IV line warmer, which the IV line goes through this set and it is closed and it warms the IV set as the IV fluid flows. Then you have this warm cupboard. This warm cupboard is very useful. So instead of using the garam panacha batlia in which you put your buckets, in the bucket the warm fluids, you have this warm cabinet. This is basically used in the biochemical or the microbiology to heat the various cold agar and the red agar and all. So this is set at 37 degrees centigrade. So it is like a fridge. It doesn't go beyond 37 degrees centigrade. It is set at 37. So it warms the IV bottles at the body temperature. Then of course you have the hotline. Hotline is used, we use it very commonly for liver transplants and uterine transplants, where you warm the IV fluids as it enters the body. Then you warm the carbon dioxide. Now there are two types of warming of the carbon dioxide. One is the external heater and the internal heater. Now, what you are seeing here is a black round circular structure, which is just at the exit of the carbon dioxide cylinder. This is the external device to warm the carbon dioxide. Now, this was used in the late 1990s, in the early 2000s. Now it is not available and not to be used because this external warming device, so it is just like a wrap around. So you put this around just as the exit of carbon dioxide cylinder and this warms like an electric heater. Now it has caused many injuries and cylinder bursts, and also this is totally gone and not to be used. Just for historical purposes, I've shown this black device. So this is a basic device which is now used by Karl Stoll's thermo inflator. As the gas leaves the CO2 inflator, it gets heated to the body temperature. So this is the bear hugger. So this is a bear hugger which we inflate for forced warming of the body. And then this is how we drape the patient. So after painting, and so before you put the drapes, you put a sterile, plastic drape, and the area of the surgery is cut around. And over it, you put the regular surgical drapes. So the main aim is that when the surgical drapes should not get wet because of use of suction irrigation or irrigating fluids, the drapes will get wet. If you have this plastic, the patient's body will not get wet. So this is a very simple technique. This is very cheap and is very useful. Then we'll discuss about deep vein thrombosis. Now, deep vein thrombosis is though not very common, but it is very commonly seen. That's how the criteria is. It is though not very common in Indian population, but also commonly seen. And you have to be very careful, and you have to have a very suspicious mind, and especially while taking the history, if the patient gives history of deep vein thrombosis. There's a peripheral vascular disease. Patient has varicose veins, or patient has polycythemia, there is hemoglobin more than 17, 18. Patient is obese, BMI more than 30, or a pregnant lady. So these are the red flags which you have to start prophylaxis for deep vein thrombosis. Always do a color Doppler of the venous system of the legs. and must find out if there is any thrombosis either in the superficial plexus or the deep plexus. To prevent this, adequate preoperative hydration, that means the patient should have a urine output between 1 to 1.5 ml per kg per hour. That means the hydration is okay. Use of sequential compression devices. So this is a sequential compression device. Everybody must have used it, which is commonly to be used, in which there are two types. One is only for the ankle and the calf, and there is another for the calf and the thighs. This device has to be started before giving anesthesia and not after anesthesia. And the pressure to be set in this sequential compression device is 40 millimeters of mercury. So this will pump the blood from the periphery of the leg to the upper extremities. Then use of subcutaneous low molecular heparin. As per the guidelines, you can give 12 hours before a surgery, and then you can restart 12 hours after surgery. Patients with DVT and history of deep thrombosis, you can even put an IVC umbrella and filter. And before removal of sequential compression device, start passive physiotherapy and early mobilization of the legs. And then you can remove the sequential compression device after 24 hours to 36 hours after surgery. Now, certain points regarding prevention of positional injuries, very common. Usually the patient's hands are like this, and then the surgery starts, the assistant starts, and the hands go like this, and then go like this, and then it goes extended. So there's an injury to the brachial plexus. So better to keep both the arms by the side of the patient. So like this. So you keep both the arms by the side of the patient, you attach all the monitors, the patient's arms are draped by the OTD, and then you can have extension lines, and you can see the extension lines with a three-way. You can give all the IV drugs and IV fluids and anesthetic drugs through this. So this will prevent the hyperextension arm. Then comes the injuries due to lithotomy. Injury due to lithotomy can be prevented by putting this silicone pads in the lithotomy position. You can see the blue colored lithotomy pads. This is very important. Best ideal would be to use Allen stirrups. So these are costly Allen stirrups. We, of course, in our center, we use it very routinely. This will prevent definitely all the problems of DVT and problems of nerve compression. And if you're using shoulder braces for head low position, you are using shoulder braces. Make sure that the shoulder braces have proper silicone paddings. Otherwise, can lead to the brachial plexus injury. Now, some key points regarding if the patient is a cardiac patient coming for laparoscopic surgery. Say ejection fraction around 30%. How to manage such patients? Now, this itself is a huge another lecture. I've just added a silent points. So, monitoring, intra-arterial line monitoring with continuous blood pressure monitoring, PA catheter depending upon the type of surgery and the type of medical condition and the type of heart disease, transesophageal echocardiography depending upon the patient condition. Again, ECG monitoring should be 5-lead ECG monitoring instead of 3-lead, which has a continuous ST segment analysis. Gasless laparoscopy, which of course I will, in the later slides, I'll explain what is gasless laparoscopy. And think about for open laparotomy. You started pneumoperitoneum, patient is not tolerating pneumoperitoneum. Why be insisting that you have to do the laparoscopic surgery? You can convert it to the open surgery, and you can have the advice of a senior laparoscopic surgeon, of course, have the second anesthesiologist friend. Intraoperative management, if the patient is a cardiac patient, of course, the gas insufflation has to be very slow till you get the set intrapleural pressure. Keep the set intrapleural pressure very low. Usually the standard is between 12 to 14. Keep it down up to 8 to 10 millimeters of mercury. After giving anesthesia, complete hemodynamic stabilization and optimization, and then start pneumoperitoneum. And then after pneumoperitoneum, again stabilize the patient hemodynamically and then give position. All, of course, needless to say, keep the emergency drugs and cardiac drugs and defibrillator ready. Experienced laparoscopic surgeon, say a second anesthesiologist friend, and of course, standby cardiologist will definitely decrease your stress. So now I talked about what is gasless laparoscopy. We used to do it very routinely in the early 1990s and up to the late or the early 2000s. So this is gasless laparoscopy. The peritoneal cavity is expanded using abdominal wall lift by using a fan-shaped retractor. This avoids hemodynamic and respiratory changes. In those times, we didn't have very common use of carbon dioxide. Some centers had carbon dioxide, but that time we used to use it. So this abdominal lift was very good and gaseous laparoscopy. So this avoids the hemodynamic and respiratory changes and the consequences use of pneumoperitoneum and carbon dioxide. Cyclic circulation and renal circulation is not altered. So this is how this fan-shaped ventricle looks. This is three-shaped along with the pulley. You can see these rings, and there's a towel clip attached to the umbilicus and two areas of the abdomen, and with the pulley they lift it up. So very useful in cardiac and pregnant ladies, and as per some studies, it decreases the port site metastasis in oncosurgery. It improves the surgical vision because that time we used to have a set interval pressure between 8 to 10. But why this technique has not become popular? Because this pulleys interfere with the surgical exposure and the movement of the telescope and the surgical instruments. That is why this technique has not become popular. Now, how to manage a pregnant lady coming for laparoscopic surgery? It is better to operate during the second trimester, ideally before the 23rd week, because it minimizes the risk of preterm labor and it maintains adequate intra-abdominal space for working. So as the uterus is growing because of pregnancy, it will occupy most of the space in the abdominal cavity. So if the pregnancy is less than 23 weeks, it is better to operate during that time. Use of tocolytics. Now there are many papers whether to use tocolytics or not to use tocolytics. Some papers favor tocolytics, some papers favor not to use tocolytics. So debatable question. Then while entering the first trocar, use an open technique to enter the first trocar. There's an open Hassen's technique. And after you enter the abdomen, then you start the pneumoperitoneum and the subsequent trocars can be put under vision. Transvaginal ultrasound to fetal monitoring is very useful. Now, mechanical ventilation has to be adjusted to maintain the physiological material alkalosis. This is to allow good oxygen transfer to the baby and maintain low intra-abdominal pressures of between 8 to 10 or maximum between 8 to 12, not more than that. Now, if you get a pediatric patient, a small baby, 8 years old baby coming with a twisted TO mass or twisted ovaries, how to manage this? This all those topics which I am telling you, pregnant ladies, pediatric patients, itself is a huge topic which can be discussed over half an hour to 1 hour. Just as silent points. So pediatric patient coming for laparoscopy, say appendicectomy, twisted ovarian mass or twisted ovaries, pneumoperitoneum produces the same changes that of adult. So the set intra-abdominal pressure is of course less. It depends upon the size of the baby and the weight of the baby. So intra-abdominal pressure is between 6 to 10 millimeters of mercury. Now we are even doing laparoscopic neonatal surgeries where the set intra-abdominal pressure is less than 3 millimeters of mercury. So that this technological advances are taking place. Then some points, just it's a huge topic, is about VATS, video assisted thoracoscopic surgeries. It is always better to put a double lumen tube and give anesthesia by giving a differential lung ventilation. Once you collapse the lung, this totally collapsed lung will increase the space in the thoracic cavity. In fact, you can do the surgery without even using a CO2 insufflation. If you have to use the CO2 insufflation, the set intrathoracic pressure should not go beyond 5 to 7 millimeters of mercury. This itself is a huge topic. I will not go. So the next is that perioperative. Now let's go to the robotic surgery. So perioperative concerns and management during robotic surgeries. So it is very much similar to that of any advanced or prolonged laparoscopic surgeries. So you can just see preparation of the OT, preparation of the patient, pre-medication, anesthetic technique, and post-op care is very much similar. Patient comes in the OT, start 2 IV lines, standard monitors for any advanced laparoscopic surgeries, combined epidural with anesthesia because usually they are a little prolonged robotic surgeries. Important points to remember. The monitor which you are attached, the cable should be a little long because once the robot is docked, the access to the monitors and to the patient's body is difficult because you're away. So the monitor should have long cables. Use of IV extension lines, at least 150 centimeters long, and all these IV extension lines should be dual locked. So there's hardly any chance of getting disconnected during the intraoperative period or during the surgery. Nasogastric tube, use of urine catheter with urine meter to measure urine output. Of course, again, there has to be a long length of the breathing system. So as you have long length of monitors, long length of IV lines, you must have long breathing system tubings. Endotracheal tube always has to be secured not only to the patient side, also to the machine side. Hands have to be kept by the side. and like we have seen in advanced laparoscopic surgery. This will increase the space around the patient and it will allow proper docking of the robot. Invasive lines, of course, depending upon the type of surgery and the expected blood loss and the patient medical condition, again stress on the heating devices. So positioning after anesthesia, you start giving the position depending upon the position. The use of gravity will displace the various organs and the intestines. After positioning, as you know, endotracheal tube has to be doubly secured and check for an entry. Also, you have to check for proper positioning of the monitors because during positioning, the ECG leads can come out, the pulse ox can come out. So after positioning, you always secure that the monitors and ETCO2 and the pulse oximeter are in proper place. You properly stick it with a stick plaster. And of course, pressure padding of the various pressure points. So these are the various robotic ports. You can see those ones with the green, they are little larger ports than the routine laparoscopic ports. And once the ports are put, of course, again under revision, some of them put varies and then put the ports. The set internal pressure is again between 12 to 14 millimeters of mercury. So this is a draping of the robotic device. So this is a robotic device that is being draped by sterile plastic sheets. Then comes the docking of the robot. So I'll just play a little small film just to show that how the robot is docked. So it's a huge bulky device. This is a robotic device. So it requires one person to steer it up to the patient. So this is the docking of the robotic device to the robotic laparoscopic ports. So this is how it looks after docking. So as you can see, it's a bulky device. You need one person to steer it up to the patient. Once the robot is docked, then access to the patient's head, airway and IV lines is quite difficult. Another important point is that once the Da Vinci robot is docked, you cannot change the patient position. So any events like hypotension has to be treated with IV fluids and inotropic drugs. Then you always have to ensure there is clear space around the patient. Because once the robotic arm and the robotic device starts working, the robotic device will not have the pressure sensation that this is patient's body. So during the movement of the patient's robotic device and the robotic arms, there can be crush injuries to the patient's body. So ensure there is clear movement of the robotic arms around the patient bodies. And the last point, which is very important, is everyone in the OT, right from the mama, maushi, technician, anesthesiologist, assistant surgeon, chief surgeon, must know how to unlock the robot as early as possible. We have come down to up to 15 to 20 seconds. So if there's a surgical emergency or a medical emergency, you must get complete access to the patient's body as early as possible. The other important point about the robotic device is that just as you seen as the gasless laparoscopy, the robotic device itself can lift the abdomen. So this is called as a lap lift. This will not only increase the space inside the abdomen for the surgeon to operate, also we can decrease the set internal pressure. So this is a big advantage of using the robotic device. Then the important points, you can continue, ensure there is complete muscle relaxation throughout the procedure. So that is the use of peripheral nerve stimulator. If the patient bucks during the procedure, then there is a high incidence of either injury to the organs or to the various intestines. Then physiological changes and IV fluid management, hypothermia management is the same that of any advanced laparoscopy or prolonged surgery. So we have come into an era of advanced laparoscopic surgery and now robotic surgery. So we have to rise to the situation and to understand how to give a better perioperative care. Now comes the important part, which is very important to us, is what would be the post-operative pain management after laparoscopic surgery or a robotic surgery. So though it is said that it's a laparoscopic surgery, small incision, patient should not have pain. No. It is very painful after laparoscopic surgery in the post-operative period between 0 to 4 hours. The pain score is just as the same as that of an open laparotomy. But after, of course, after 9 to 24 hours, the requirement of analgesic requirement definitely goes down as compared to the open surgery. So what are the pains after the laparoscopic or robotic surgery? There are 3 types of pain. One is the incisional pain, that is incision because of putting the trocars, intra-abdominal pain because of the stretching of the peritoneal cavity, and the referred pain and the retroperitoneal pain, which is because of the stretch of the diaphragm. So etiology of laparoscopic pain is that incision on the abdominal wall, induction of the visceral trauma and inflation and causing pneumoperitoneum and peritoneal stretch, peritoneal irritation because of carbon dioxide, blood, bile, intestinal spills, causes carbonic acid, which stimulates the diaphragm, and the stretch of the abdominal wall. Another important point here to remember is that never go beyond 14 to 15 millimeters of mercury. There are surgeons who tell, oh, we'll keep it up to 15, we'll keep it 18. Sometimes they can go up to 20 millimeters of mercury. Nothing you manage. This will cause severe pain in the retroperitoneal areas, and this pain is very difficult to manage if there's retroperitoneal stretch and the retroperitoneal pain is very difficult. The requirement of analgesics definitely goes up. As per the recent recommendations, post-op pain management should be always multimodal. Because it is laparoscopic surgery, you just give one Anapar or one Tramadol or one paracetamol, it never works properly. Always have a multimodal approach. So multimodal approach, NSAID group of drugs, COX inhibitors, nerve blocks, which we usually use. Then NMDA receptor antagonist like ketamine and thing, anticonvulsants like gabapentin and pregabalin, opioids, fentanyl, morphine, whoever uses it, and of course tramadol. Then we have the various local anesthetic blocks which we commonly use as abdominal wall infiltration, field blocks, rectus blocks, TAP blocks, intraperitoneal local anesthetic blocks, mesosalpinx or fallopian tube blocks, intrapleural local anesthetics, and of course epidural and steroids, epidural and spinal. The most important thing is that when you're giving a local block or a nerve block or a field block, it is important that you give the block before the surgical incision and not at the end of surgery. This is the important point, is that before the pain starts, you block the nerves, not at the end of surgery. So this was a ultra short, condensed. Each topic can be expanded to another half an hour, 1 hour lecture. So which I have tried to condense everything in one small lecture of about 30 minutes. Points which I didn't cover was laparoscopic obesity surgeries, which itself is another huge study. Of course, the principles are the same. Physiological change is absolutely the same. So the final message is that always combine a regional technique, whether it could be an epidural or a nerve block, along with general anesthesia for any advanced or prolonged laparoscopic surgery or even minor surgeries. Do not compromise on safety. So monitoring end-tidal CO2, closed circuit, and proper workstation ventilation. Hand ventilation can be very useful for, say, for small surgeries, but for prolonged laparoscopic surgery, you need a manual ventilator, which will give a fixed tidal volume. You can adjust the airway pressure. You can convert from controlled mechanical ventilation to even pressure support ventilation, depending upon the ETCO2 and the airway pressures. Of course, teamwork, which I've always mentioned, experienced surgeon, a second anesthesiologist friend will definitely decrease your tensions. So thank you for a patient listening. So before I end my talk, I would like to share a very important event of ISA National and very important for all of us. Last Sunday, I was at Chennai and we have now official registered ISA office called as ISA National Registered Office. It is called as ISA Balakrishnan House. The address, this is the permanent address now. If you can note it down, 1203 Casa Grande, Monte Carlo, Mount Road, Saidapet, Chennai. This is the official address, permanent address of ISA. So this is, I was felicitated when I went to attend all the past GC members by our Honorable President and Honorable Secretary. Now, why this house was called as the ISA Balakrishnan House? Now, when the society was registered, the official address for this society was at Dr. Balakrishnan House. So this is the past president, Dr. Balakrishnan sir, on whose address all the official communications from the income tax, charity commissioner, and all the documents, physical documents, which were of course now it is digitalized, was at his house. Now it has been shifted to the ISA office. It was indeed a proud moment for the ISA. So this was the home puja of Vastu Shanti. So long live ISA and Jai Hind. Thank you so much for the patient listening.
Thank you, sir. Thank you, sir. Very elaborative and you touch every topic in lab anesthesia, and you also touch on robotic also. One question from the question box, please check and answer that. I will read. How to deal with the question from Dr. Sachin Odmare. How to deal with surgeon during surgery for their demands to increase CO2 pressure?
Yeah, this is a very good question because especially when you're putting trocas, they want the pressures of the intraoral pressures to be very high. कधी 14चे 16 करतात, 16चे 18 करतात, कधी even they go up to 20. This is the time when you have to put your foot down. You have to say that you cannot go then 14 to 15 millimeters okay. Once you put the trocas, come back. It is our that you come back to 14, 12 millimeters of mercury. Otherwise, there can be severe hemodynamic changes. And of course, post-op pain because of the retroperitoneal stretch. So in such situations, you have to be stern and you have to put your foot down. Okay, this is not. So this physiological changes, even that is why the teamwork. He सगळ्यांना माहिती पाहिजे, not only the surgeon, even the anesthetist. So update on surgical anatomy and update on surgical pathology, physiology. They have to know it. So this lecture I have giving the same lecture to even all the surgeons and the gynecologists. Because anesthesia part it is very small. It is basically the physiological changes and the complications because of this. So you have to put your foot down and say that no, sir, you cannot go. There can be severe bradycardia, there can be severe hypotension, etc. You can go down. So this is where you have to put your foot down.
So there is one more question in the chat box.
हाँ बोल.
Please elaborate intraperitoneal anesthesia in laparoscopy.
Intraperitoneal.
So basically, Dr. Naseem asking for intraperitoneal, you give local anesthesia.
Yeah, this
about that.
So this technique of intraperitoneal anesthesia
infiltration. Yeah.
Intraperitoneal पण आहे and intrapleural पण आहे. There are both.
Okay.
So in intraperitoneal lesion of anesthesia is that there was a device by Karl Stoss. It was called as a BP mist. BP mist was a device in which local anesthetic was added, either bupivacaine or ropivacaine, depending upon the patient's weight. And this device used to make a mist of that local anesthetic, and it was to be sprayed in the intraperitoneal cavity. It used to get attached to the various peritoneal receptors like a mist. But why this device has not become popular, this BP mist, is because of the expense. If you don't have this device, there are many surgeons which uses a suction cannula, that you give a syringe of the local anesthetic, bupivacaine or ropivacaine, and they instill it just below the diaphragm. So these are the various techniques which they are used. It is sometimes beneficial, most of the times it is not beneficial. Patients to vary, because there are still not many trials that whether intra-abdominal installation of local anesthetics have definitely decreased the pain scores. So this is why the multimodal ways of post-operative period. That is why I included this post-operative pain management in laparoscopic surgeries. The multimodal way of post-operative management is equally very important. Sachin.
Sir, one more question from same Dr. Naseem asking how to manage shoulder pain in post-op period.
Yeah, shoulder pain, I have of course mentioned it. The shoulder pain, which in my slides, the shoulder pain is basically because when there is blood, bile, intestinal contents, and constant use of suction irrigation. CO2 is already there. There's carbon dioxide and water vapor is or water which is interacts. Water interacting with this and carbon dioxide causes carbonic acid. And this carbonic acid stimulates the diaphragm and causes the shoulder pain. So this can be either managed by either removing all the bile and the less use of suction irrigation. Some of them irrigate the patient, but sometimes it is useful. At the end of the procedure, they use irrigating fluids, and basically you must ask the surgeon to remove all the carbonic acid from the base of the diaphragm, so that all this carbonic acid comes out. Definitely decreases the shoulder pain. The other thing is that many techniques have been tried to decrease the shoulder tip pain. One is intrathecal opioids, epidural opioids, intrapleural local anesthetics. All techniques have tried. Some techniques have worked, some techniques have not worked. But depending on that, you have to use a technique.
Sir, from Dr. Pankaj Gupta sir has asked one.
Yes, Pankaj. Pankaj,
Nice stuff, Jana sir. Do you suggest pre-op LA at port insertion site? Ideal post-op anesthesia plan you follow, including preemptive anesthesia?
Yeah, in my practice, where we do a lot of prolonged laparoscopy and robotic surgeries, I always use a regional technique. Especially for prolonged laparoscopic surgery, epidural anesthesia is one of the best, because you can give local anesthetic, you can add opioids to it. It definitely decreases the hemodynamic changes, intraop management, and decrease the anesthetic requirement of GA. And post-op, you can keep the catheter for 40 to 72 hours. So use of epidural anesthesia along with opioids, it is definitely useful for laparoscopy and robotic surgeries. So epidural is one of the goals. If it's a short procedure, then give a tap block. Of course, give an adjuvant, either you can dexmedetomidine or dexamethasone or opioid, and then give GA. Always ensure that your nerve block should be before the surgical incision, then at the end of the surgery. This is the main thing.
Sir, other question from Dr. Mohan Patak.
Mohan Patak.
What precautions for compromised left ventricle dysfunction?
What compromised left?
Precaution. What precautions to be taken for compromised LV function
dysfunction? It depends upon what is the grade of left ventricular dysfunction. If it is grade 1 dysfunction, grade 2 dysfunction, grade 3, grade 4, depending upon that. Usually grade 1 and grade 2, you can manage this thing. But if it is grade 3 and grade 4, then comes the role of invasive lines. Whether it is a central line, you're monitoring the output and input, putting an arterial line, getting a minute-to-minute intra-arterial blood pressure monitoring, and then you can manage it. So basically, there should be no much of tachycardia. So use of nerve blocks and epidural anesthesia is very good. If there's tachycardia, in spite of all this, use of beta blockers like either metoprolol or esmolol to decrease the heart rate. At the same time, there should be not sudden hypertension. So the use of nerve blocks is very useful. If there is hypertension, try to decrease it with either dexmedetomidine or use of other agents to decrease the blood pressure. So these are the ways to deal with left ventricular dysfunction.
Sir, one more question from Dr. JC, madam.
Yeah.
Surgeon asked for extreme head low. How unsafe is it?
Extreme head low, it depends upon the patient's medical conditions. As this extreme head low comes especially when we're doing a robotic radical prostate, when the head low goes up to 45 degrees or 50 degrees. In extreme head low position, you have to be very careful. If the patient has a medical problem, has a low ejection fraction, then giving head low with a low ejection fraction with pneumoperitoneum can be dangerous to the patient. So while giving head low, it has to, one thing is that you have to give it very gradually. Slowly, depending upon the hemodynamic changes, you give head low for 10 degrees, wait for the hemodynamic correction, then again give head of the cerebral venous plexus and increase in the cerebral intracranial tension. In the post-operative period, patients usually after say 4 hours or 5 hours do not come out very satisfactorily. In these conditions, there can be evidence of cerebral edema. How to diagnose cerebral edema? Do a simple fundoscopy. Retinal fundoscopy will immediately find out if there is cerebral edema. There can be definitely easily found out. If you see the patient is moving their arms irrelevantly and patient is confused and irritable, do not extubate such patient. Give ventilation. You can even add mannitol because to decrease the cerebral edema, or even furosemide or Lasix, and then extubate after some time. You can do an APG, see for any respiratory acidosis. Continue mechanical ventilation. You can go for 1 hour, 2 hours, get the ABG to normal, get the patient to be stable, and then extubate in such patients. So severe head low position is a very difficult thing because surgeon if you give a regional anesthetic block, say you give an epidural, the bowel is contracted. So the need for surgical persons to ask for severe head low definitely goes down because the bowel is contracted and does not come back into the surgical field. So the need for severe head load definitely goes down if you are given a regional block like epidural or spinal.
sir,
Huh.
another question was almost you given answer, Dr. Smita Joshi madam. Treatment of cerebral edema with deep head low position in
Yes,
robotic surgeries.
yes. This is a very common, very common problem, because you give 45 degrees, 50 degrees head low, and then you go on for operating for say 3 hours, 4 hours. Patient is in head low position with pneumoperitoneum. Veins and the blood from the brain will definitely not come down into the heart, because they'll be stagnated inside the cranium. Along with that, the lumbar venous pressure also is high. So the cerebral venous drainage from the brain and the skull will definitely come down. Along with that, it is hypertension and tachycardia. So this even arterial pressure will go up. Along with that, there is vasodilation because of hypercarbia. So there is all combination raised to raise intracranial pressure. In such conditions, it is always better see how the patient comes out. If the patient you suspect there is some cerebral edema, do fundoscopy. Get used to the procedure of fundoscopy. Fundoscopy is very commonly done in intensive care and ophthalmic surgeons. So in that, do proper mechanical ventilation, give mannitol, give furosemide. Once the patient is stable, then go for extubation.
Another question, sir, from Dr. Pradnya madam. Red flags when you will ask surgeon to open.
Red flags when the surgeons will ask to open is very good question. This happens because the surgeons, they want, I want to do the laparoscopy, because they have promised the patient, yeah, I'll do laparoscopy. So the red flags is that when the patient is not withstanding the pneumoperitoneum. That's the severe tachycardia. In spite of all the things you have done, severe tachycardia, blood pressure goes up, ETCT starts going up. Most commonly, the ETCT will start going up when there is a subcutaneous emphysema. When the patient is very thin, there's hardly any subcutaneous tissue, and they have taken a large incision to put a trocar. So as the instruments go up and out, come in and out, there is going to be subcutaneous emphysema. The first sign of subcutaneous emphysema is a rise in the ETCO2. So that is the time. And of course, blood loss is there. Patient is not withstanding the pneumoperitoneum. There are cardiac arrhythmias which is going on. There is a time when you should say, okay, or they're unable to progress in their surgeries. You're doing a lap call, the patient is badly stuck. What we usually follow in our practice, and most of the other thing, is that up to 1 hour, if the patient is okay and the patient is sustaining pneumoperitoneum, up to 1 hour, you can keep on trying your laparoscopy and you're unable to find out the callus triangle, unable to dissect. You give 1 hour. After 1 hour, if you're unable to proceed, that means that at the beginning of 1 hour, at the end of 1 hour, if there is no surgical progress, it is better to open. So that's how we follow.
Sir, one more question.
Yes.
From Dr. Naresh Paliwal, sir. Your plan of anesthesia in patients with respiratory comorbidity. Respiratory
comorbidities, as you have seen in my lecture, we do a pulmonary function test. If the forced expiratory volume coefficient is less than 70%, and in the diffusion defects is less than 80%, in the PFT, these are the patients, these are red flags. These are the patients who will most probably or most definitely will require post-operative ventilation. So if you know there's a COPD, or there's chronic bronchial asthma, or some respiratory problem, atelectasis, or some bubble, or cavities, if these patients have a PFT showing all this, along with PFT, always do an ABG to find out if there is washout of CO2 or retention of CO2. In such patients, it is better to avoid to go for a center where there is elective postoperative ventilation or ICU with a ventilator. So these are the problems if the patient has a respiratory problem.
Sir, one more question from Dr. Shailesh Kulkarni, sir. Any role of LMA in laparoscopy, your experience?
Yeah, LMA, of course, definitely can be used. There are many papers who have done laparoscopic surgery under LMA, no problem. LMA is to be used when the laparoscopic surgery is less than 60 minutes or 45 minutes. In those patients, and in those patients when the patient is supine or in lithotomy position. That means the patient's body is in supine position and maybe you can have a lithotomy. But if you have a patient who is in a lateral position or a semilateral position or in prone position, never use the LMA. Use a proper cuffed endotracheal tube with controlled ventilation in closed circuit. LMA in small procedures can be definitely done. The simple gallbladder, simple appendix, or simple tubal ligation in a supine position, LMA definitely can be used. But any surgeries which is going more than 1 hour or more than 1.5, in a different position, say lateral or prone position, always put a proper cuffed endotracheal tube. That is what is recommended.
I think all questions are answered by sir. Very nice talk on lap and robotic surgery. It's a very honor from our ISA Nanded, sir. You come on our platform with DigiShield, our sponsor.
Thank you. Thank you so much. अजून काय असेल तर सांग.
Dr. Naseem Akhtar told to panelists and hosts, please arrange CME on labor anesthesia if possible. This is excellent presentation. Thank you very much, sir. Thank you, madam. Almost all people given thanks to Jana, sir.
Thank you.
This is our silver jubilee and platinum jubilee celebration year. So we are conducting this weekly case meets. Last 2 weeks, due to some problems, I'm not able to conduct 2 case meets. But this is a very wonderful talk given by Dr. Jana, sir. And at par, almost all topics are touched by Jana, sir. Sir, one question from me is, from anesthesia point of view, surgeon started after giving spinal or on lap appendix or even for hysterectomies or any other procedures for after they want immediate head to positions, and how to tackle these things from for junior Bs or for
because
newcomers.
they are what I do. Even I used to do a lot of laparoscopic surgeries under paralysis. I must have done more than 3,000 lap cholecysts or even lap appendix and even laparoscopic hysterectomies. Now I have stopped doing it. Now I started combining it with laparoscopy with epidural. Usually when the surgeon comes in, you give spinal, patient is settled in supine position, and they give position. By the time they wash, they arrange the laparoscopic instruments and all. It is usually more than 20 minutes. Because I have seen in so many places, I always advise that the patient is the last one to enter the OT. It is usually the reverse. Patient enters first the OT, then you start IV line and this thing, and then this sister will put on the laparoscopic trolley. So usually by 20 minutes, the spinal level or this thing is fixed. And then of course you can definitely give head low position. But while giving head low, you have to give it slowly. Directly from supine, directly you give a 30-degree head low, it is better to avoid. Start with 10 degrees, wait for some time, see for hemodynamic changes, take one blood pressure monitor, reading. Then again you give head low for 20 degrees. So that's how you have to go slowly. Don't go fast. Other thing is that when they put the trocar, don't start or don't encourage the surgeon to start the intraperitoneal insufflation at a very fast rate, say 20 liters per minute. On applying supplemental, the gas flow is up to 20 liters. Don't start. Start with 3 liters or 4 liters. Slowly it starts. Slowly it expands. So hemodynamic optimization is better when there is slow gas insufflation.
Sir, one more question from Paliwal, sir.
Yes, sir.
Sir is asking, why not use isobaric drugs for this?
You can use. There's nothing. Our main aim is to use regional technique, whether it is epidural, spinal, or nerve blocks, to blunt the hemodynamic changes of pneumoperitoneum. Isobaric drugs, there is absolutely no contraindication. You can definitely use. Once it is fixed and the level is fixed, you can give head up, head low position, and you can proceed with any other. But of course, in prolonged laparoscopic surgeries, when the surgery is going beyond 3 hours, then the use of epidural is more beneficial than giving spinal. If the surgery is less than 2 hours, spinal with general anesthesia is definitely okay. But if the surgery goes beyond 3 hours, 4 hours, or 5 hours, it is always better to combine it with epidural and GA. That's what I feel.
Sir, one question from me.
Yes.
I want to ask about that local anesthesia or local drugs you infiltrate in intraperitoneal. How much you use regularly?
As per the patient's body weight. If you're using bupivacaine or ropivacaine, 2 milligram per kg body weight, mix it with normal saline, not distilled water. This is another important thing. Whenever you are using local anesthetic block or local anesthetic spray, as per the body weight, you calculate it and mix it with normal saline, and then you can give a spray, a split. So that's how it is. But absorption from peritoneal cavity is much faster, just like giving IV drug. So you have to be very, very careful. So it's better to start with 1 to 1.5 milligram per kg body weight Don't go up to 2 milligram per kg body weight. So start with 1.5 because you can dilute it. So you say you can start with 1 milligram per kg body weight of bupivacaine. Dilute it 4 times. So you get a good volume and make a spray.
Sir, I think no questions in question box. Overall, you cleared almost all questions in a time, and really great and very much happy on ISA Nanded part that
Thank
we
you, sir.
as a secretary and on the behalf of president, sir. I'm very much glad to and see you in the future as early as possible from our side.
Yes,
And,
I'll definitely come. You invite.
yes,
I'll
sir.
come.
And very much congratulations for your future dreams
Endeavor.
and perspectives from ISA Maharashtra and ISA Nanded also.
Thank
We
you.
give you a lot best
Yes,
luck.
I definitely need all the support from all the members of ISA.
Yes, sir. Definitely. So
So
thank you, sir.
we'll meet in person definitely.
Yes. So I think we conclude this session now.
Yes. Thank you.
Thank you, sir. Thanks a lot.
Thank you.